Question 71. Which one of the following drugs is used to reduce the risk of diabetic nephropathy? Is it a loop diuretic such as furosemide, an ACE inhibitor such as ramipril, an aldosterone receptor antagonist such as spironolactone, low-dose aspirin, or the osmotic diuretic mannitol? Okay, so diabetic nephropathy is a disease which is caused, as you might imagine, by diabetes. And what it does is it affects the blood vessels that lead into the kidneys, which causes them to become either damaged or in some way inhibiting blood flow. And over time, this can lead to kidney failure. So that involves a number of symptoms as well. You tend to get edema, particularly around the eyes and ankles, because your kidneys are not filtering through, and so you get pooling at different parts of the body. It tends to cause high blood pressure, increases the amount of protein found in the urine because it's not being filtered out correctly, and it also will decrease your urine output. So if a patient is suffering from diabetic nephropathy, given those are the symptoms, which of these do you think is going to help them? So let's go through our options and see what we have. So a loop diuretic such as furosemide. So loop diuretics can be used to help reduce the fluid buildup in the body, so they can help with the edema that you're suffering from, but they're not directly addressing the underlying cause of what's causing the nephropathy. They're only dealing with the symptoms. So that might be something that in certain situations we consider to help manage it, particularly if a patient has a particularly high level of edema, but that wouldn't be our first line call. Next, we have an ACE inhibitor such as ramipril, and this is actually our correct answer. So why is that? So ACE inhibitors are used to treat high blood pressure. That's their most common use, but they've also been found to reduce the risk of diabetic nephropathy and other symptoms of diabetic nephropathy. And they do this by lowering both the blood pressure and reducing the amount of protein, so albumin, in the urine. And they do this by dilating the blood vessels. So this is what helps to lower the blood pressure. So that will reduce the strain on the kidney. And one of the reasons that we get this diabetic nephropathy is because the afferent arteriole, which leads to the nephron, ultimately leads to going into the glomerulus of the kidney. This becomes constricted or in some ways damaged or impaired. So not enough blood is going to the kidney, which affects the kidney's ability to filter out all of the bad stuff that we need to get out of our system. So ACE inhibitor comes along. I say that like it's a Superman. ACE inhibitor comes along and it helps to protect the kidney by dilating these blood vessels and limiting the effect that diabetic nephropathy has. So it deals with the underlying cause of the condition far more than a loop diuretic would. So in this particular situation, our first line treatment would be an ACE inhibitor, most likely ramipril. So we'll just quickly go through the others, why it's not those. So an aldosterone receptor antagonist. So things like spironolactone, these are what are known as potassium sparing diuretics. So they are quite often used in combination with other diuretics, and they will again help with the symptoms of edema. They help to reduce fluid retention, particularly in conditions such as like heart failure, or if the patient have liver psoriasis. But again, much like with a loop diuretic, it's helping to deal with one of the symptoms caused by diabetic nephropathy. It's not dealing with the underlying cause. That wouldn't be our first go-to. Low-dose aspirin. So this is commonly used to reduce the risk of certain cardiovascular events, a myocardial infarction or a stroke. And again, there's a similar theme running through these. It helps to reduce the risk of certain cardiovascular complications and some of the effects caused by diabetic nephropathy, especially if there are other comorbidities. But again, it's not directly affecting the underlying reason why we have it. And then we have mannitol, which is an osmotic diuretic, and this is used to reduce the intracranial pressure and intraocular pressure. So the way it does this is by drawing water into the kidneys, which will increase urine production, and that helps to reduce pressure. So it's something that we tend to use if there is risk, if there's like excessive pressure, particularly around the eyes, sometimes around the brain as well. But again, it's not reducing the risk of diabetic nephropathy. So our correct answer is an ACE inhibitor, ramipril. Question 72. A 58-year-old man of Caucasian ethnicity was found on a routine GP visit to be hypertensive with a blood pressure of 170 over 105 millimoles of mercury. After appropriate lifestyle measures, his blood pressure was still elevated and he was started on amlodipine, 10 milligrams daily. After a month of treatment, his blood pressure was 160 to 95. So fantastic. We've reduced it a little bit. We still want to bring it down a bit more, but at least we're, having some effect. Amlodipine is associated with which two of the following? Okay, so amlodipine is a calcium channel blocker. So what it does is that it blocks the influx of calcium ions in the vascular smooth muscle cells. And then by inhibiting this calcium entry, it prevents muscle contraction. And this leads to the relaxation and dilation of arterial smooth muscles, which has the desired effect of lowering blood pressure. So with that in mind, let's go through these and see which of these two are a common side effect. So bronchospasms. So amlodipine is not known to cause bronchospasms, so it's affecting the blood vessels in the heart. It doesn't tend to affect the airways, and it's not something like certain beta agonists that might interact with different parts of the body. It doesn't cause any kind of change in the airway, so it's not a bronchospasm. Decreased cardiac output, actually quite the opposite. So amlodipine, because it's used to treat hypertension and angina, it actually reduces the heart's workload, and this will have the benefit of increasing oxygen delivery to the heart. So if it's going to reduce the cardiac output, we wouldn't be giving it. It's probably going to cause more problems, like one of the reasons that a patient would be suffering from hypertension is because they're trying to get this blood around their body, and then their heart tends to be working overtime. So what we want to try and do is reduce the amount of vasculature resistance so that the heart doesn't have to work quite as hard. So no, it is not going to decrease cardiac output. It can lead to the development of diabetes mellitus. No, this just not the case. It's completely safe to use in patients that have diabetes, and that's not one of the risk factors involved in it. Diarrhea. Diarrhea is, again, not a common side effect of amlodipine. It can cause certain other gastrointestinal side effects. So amlodipine has been associated with nausea, sometimes with abdominal pain, and constipation actually is something that occurs. So kind of the opposite of diarrhea. It can cause constipation, but it does not cause diarrhea. Next we have gout. So gout is a form of arthritis which is caused by a buildup of uric acid. So you get these uric acid crystals build up, and that's what causes the painful association. And amlodipine is not associated with it. So it's a calcium channel blocker. It doesn't cause an elevation to levels of uric acid in the blood, so that's not one of the side effects. Headache. So yes, headache is unfortunately one of the side effects. In fact, it's one of the most common ones. It depends on what study you're looking at, but just joyful when you're looking at metadata across the population. It tends to be less than 10%, and different studies will put anything from 1 to 9%. So I don't feel confident in saying. Basically, the best way to say is about less than 10%, so less than 1 in 10 will experience a headache, but I don't feel confident in saying how many within those. So 10% or less would be what I would say. The exact reason why it does this is not fully understood, which comes up a lot in medicine. We're still researching a lot of it. We don't fully know why amlodipine tends to cause headaches. It's believed to be related to the vasodilatory effects, but we're not entirely certain why. For instance, like if a patient has a heightened intracranial pressure, then yeah, we would expect that to cause headache. So we don't fully know why the dilation of the blood vessels will lead to a headache. We just know that unfortunately it does. So headache is one of the common side effects of amlodipine. Next we have hypoglycemia. Again, much like we would expect to see hypoglycemia in certain anti-diabetic medications, but not with a calcium channel inhibitor. Liver toxicity. Amlodipine is not associated with liver toxicity. It is primarily metabolized in the liver, but it doesn't cause liver damage, or it's a very rare side effect, so it's not something that we typically be looking out for. Again, technically, all of these conditions, there is a chance that it could cause it, because there could be some mechanism that is just incredibly rare. There could be some genetic disorder, but we're looking at less than 1%. So we're more, this question's more asking about what are the slightly more common side effects, so things that are, you know, between like 3 to 10% kind of thing. Next, we have peripheral edema, and this is a common side effect of amlodipine. So it does this because it causes vasodilation, and because you're dilating those blood vessels, that can sometimes lead to fluid leakage into the surrounding tissues, and this is what results in edema. And you can see that in our diagram here. Usually the most common area you would expect edema is around the ankles, and many of you may have known, especially amongst the elderly, sometimes they get very heavily swollen legs and feet. Part of that is just because of gravity. That's where it tends to pull, and it is an unfortunate side effect of calcium channel inhibitors. Again, exact number not fully known, but tends to be under 10%. So peripheral edema is an unfortunate side effect of calcium channel inhibitors. And then the last one, so stroke. Nope, amlodipine is actually going to reduce our risk of stroke because it's lowering the blood pressure. It's used in treatments of hypertension, so it's going to have the opposite. It's going to decrease the risk of stroke. And then finally, visual disturbances, and again, just no. There's no known association between amlodipine and visual disturbances. Question 73, and I just want to apologize in advance. Both of my cats seem to be in heat right now, so apologies if you hear any trilling in the background. So, question 73. To reduce the patient's overall cardiovascular risk, it is decided to start him on simvastatin. Which one of the following is an important consideration? So amlodipine is likely to lead to reduced plasma concentrations of simvastatin. Amlodipine raises plasma cholesterol and reduces the effectiveness of simvastatin. Simvastatin is contraindicated with amlodipine. Simvastatin reduces the bioavailability of amlodipine, or the maximum dose of simvastatin is reduced with concurrent amlodipine. So simvastatin is a statin, as the name implies, and statins work by inhibiting the enzyme HMG-CoA, and this is responsible for the biosynthesis of cholesterol. So statins help to reduce the level of low-density lipoproteins, LDLs, in our blood, which helps to lower blood pressure. Amlodipine is a calcium channel inhibitor, and the way this works is by, again, as the name implies, inhibiting calcium channels. And this has the desired effect of vasodilating arterial vascular systems, so that, again, lowers blood pressure. So both of these will have the effect of lowering blood pressure, hence why they're common hypertension drugs, but they do so by two separate mechanisms. So with that in mind, let's run through these questions. Amlodipine is likely to lead to reduced plasma concentration of simvastatin. So amlodipine is not known to interfere with elimination of simvastatin from the body. In fact, it's actually quite the opposite. There's been some studies that have shown that amlodipine can actually increase the level of simvastatin in the blood, so it's not going to be one. Amlodipine raises plasma cholesterol and reduces the effectiveness of simvastatin. I mean, let's just think about this logically. I know sometimes with certain medications, hello tamoxifen, they tend to have some side effects that you would question, but 99% of the time it's not like that. So if we're using amlodipine to treat someone with hypertension and then it raises plasma cholesterol, it's kind of going to do the opposite of what we want it to do. So we wouldn't prescribe it for hypertension. We're not going to give someone a drug that's going to increase their blood pressure when that's the issue. So it's not going to be that. Simvastatin is contraindicated with amlodipine. Nope, so they don't have any known serious drug interactions together. In fact, simvastatin and amlodipine are quite often prescribed together, particularly in patients whose hypertension is particularly difficult to get under control, so it's not free. Simvastatin reduces the bioavailability of amlodipine, so this is the other way around now, rather than going from amlodipine to simvastatin, we're going from simvastatin to amlodipine, and this is not true. So they don't interact in any way that affects this. So simvastatin doesn't reduce the bioavailability of amlodipine, doesn't affect the absorption, neither of them affect either one's efficacy. So that leaves us with the correct answer of the maximum dose of simvastatin is reduced with concurrent amlodipine. And this kind of makes sense if we just think about it logically. So we have two different drugs that are being used to treat hypertension, and they're both going to be reducing blood pressure. So we have two separate drugs that are going to do the same thing. We run the risk of overdoing it, and suddenly the patient now has hypotension, they have too low blood pressure, and that can come with a whole host of other issues. Obviously, we tend to hear about hypertension more, especially in our Western diet, where overweight and obesity is a little bit more rampant. Hypotension is also quite a serious problem, so we want to try and avoid that when we can. In addition to that, as I was mentioning at the start, so amlodipine can actually increase the levels of simvastatin in blood, and this then increases the risk of side effects from statins. So myopathy or muscle pains, or as we talked about in the last video, rhabdomyolysis, which is a serious condition when the muscle fibers break down, and because you have those muscle fibers in the bloodstream, that can interfere with the kidneys, it can cause kidney failure. It's pretty serious, so whenever we're prescribing both of these together, we want to be very careful about the level. And as a result of that, both the NICE and the FDA recommend that if both of these are being prescribed together, then the maximum dose of simvastatin should not exceed 20 milligrams daily. So that is the correct answer. And in case you did miss the previous video, if you are giving a patient a statin of any description, make sure you warn them about muscle pains, and if they do notice any muscle pains, to come back to the doctor immediately and discontinue. Okay, well, not discontinue the medication, but as soon as they know, because we don't want to stop something that's potentially going to stop them from having a heart attack, but we do want to get them checked out immediately to make sure that nothing untoward is going on. And it may very well be the case that we do discontinue the medication and perhaps try something else to try and keep their blood pressure under control. Question 74. In light of the patient's current blood pressure, which one of the following actions should be made? So this question actually really annoys me because we have not been given any more information about the previous patient. All we know is that they've just been started on two different medications. We've just been given a calcium channel inhibitor and a statin, and yet despite not being told how much time has progressed or anything else, we're meant to be making the assumption that his hypertension is still not controlled and to go from there. So it annoys me because I know quite a lot of people that when they were doing this particular mock exam would go for a no change in regimen but review the patient, because why would you throw 3 different pills at someone without checking to see what the pills are? You wouldn't do that. But for some reason, despite not adequately explaining it to us, we're meant to assume that the 2 previous medications have been given to this patient, that they have not been effective in controlling their hypertension. So what do we now do? So I just wanted to get that little rant out of the way because it bugs me that a lot of people got this question wrong purely because it's not explained very well. But with that in mind, let's carry on. So, would you add a beta blocker such as atenolol to therapy? Would you add an ACE inhibitor such as ramipril to therapy? Would you add a bendroflumethiside to therapy? Would there be no change in regimen but review the patient after a further month? Or would you swap the amlodipine to an AT1 receptor antagonist? Okay, so add a beta blocker such as atenolol. So beta blockers are effective antihypertensive medications. They're not usually considered first line, and yes, we're meant to assume that this is first line, even though this is the third drug. Apologies, I'm not doing a very good job of containing my contempt. We wouldn't normally consider beta blockers if they don't have other comorbidities. So if this patient is showing no signs of angina, no signs of heart failure, no signs of a previous heart attack. But the main reason we wouldn't be adding atenolol is because the patient is already on amlodipine. And atenolol and amlodipine can increase the risk of certain side effects such as bradycardia and fatigue. So the reason we don't add them together is they work on slightly different mechanisms of action. So amlodipine mostly causes vasodilation of the vasculature, whilst atenolol reduces the heart rate and cardiac output. However, amlodipine can sometimes have a mild effect on heart rate. Atenolol has a significant effect on heart rate. So if you combine both of these together, it can have an additive effect of slowing down the heart rate, and that can cause bradycardia, so that's slow heart rate, and fatigue because you just don't have enough blood and oxygen going around the body. So we try to avoid prescribing beta blockers and calcium inhibitors at the same time. Add an ACE inhibitor such as ramipril. So this is the correct answer. Slightly irked about it being the correct answer, but at this point, hopefully you should be aware that if someone has hypertension, usually the first line medication we go to is an ACE inhibitor, and it's usually ramipril. So in this particular patient, and yes, I know we've given him 2 other ones, but we're meant to be assuming that this is first line treatment, and so we would try them on ramipril. So ramipril ACE inhibitor causes it blocks angiotensin 1 to angiotensin 2 conversion, and angiotensin 2 is a vasoconstrictor. So we stop the vasoconstriction from happening, and that helps to reduce the blood pressure. Next is bendroflumethiside to therapy, and I'm going to be honest with you. I know I'm meant to be explaining through these questions, but this mock paper has actually kind of annoyed me. I don't know why this isn't the correct answer. So bendroflumethiside is a thiazide diuretic, and we use that to treat patients with hypertension. Usually we'll use a thiazide diuretic as a second-line therapy if blood pressure remains elevated despite treatment with a calcium channel inhibitor, which the patient has. So why you would assume, realistically, you would probably start with an ACE inhibitor first rather than the previous 2 medications. I don't know what to tell you, unfortunately. I am sorry, this mock paper has actually frazzled my brain and annoyed me. If there was someone in the comments that can explain what I'm getting wrong here, I would appreciate it, but this one's bugged me. This one's bugged me a lot. So next one, no change in regimen, but review the patient after a further month. Again, in the context of this past paper, and it's only because I have the mark scheme that I know the correct answer is ACE inhibitor, we're meant to be assuming that the patient's hypertension is still not controlled, so we do want to be acting upon it. I don't even know how to explain this at this point, I'm sorry. And then swap amlodipine to an AT1 receptor antagonist such as candesartan. Basically, we're meant to use an ACE inhibitor first rather than an AT1 receptor antagonist unless there is a particular reason for it. I don't know, this question's annoyed me. Let's move on. Again, I apologise if there's anyone who has any more information you want to leave in the comments. By all means, please do so. I'm annoyed that I can't be a little bit more helpful with this. This question just feels off to me. So we'll just leave it at that and move on. Moving swiftly on before I have an aneurysm. Question 75. A 20-year-old woman has been diagnosed with asthma and was prescribed a beclomethasone inhaler, 100 milligrams, 2 puffs twice a day, and a salbutamol inhaler, 200 milligrams when required. Which two of the following are important counselling points? If she requires the salbutamol inhaler once a week, she should consult her doctor. She is likely to develop a dry mouth with either inhaler. She may notice a slowing of her heart rate. She should report muscle pains to her GP. She should rinse her mouth out after using the beclomethasone inhaler. She should take salbutamol prior to a precipitating event. She should use her salbutamol inhaler each morning, and the beclomethasone is likely to cause weight gain. So beclomethasone is what's known as a corticosteroid treatment. So this helps to reduce inflammation in the airways for those with asthma, while salbutamol is our standard beta-2 agonist. So this is the common one we use as a preventative inhaler, and it's the little blue one you get. So with that in mind, let's go through and see what the correct answers are. So if she requires the salbutamol inhaler once a week, she should consult her doctor. No, this is well within the realms of what we expect from someone who is having a salbutamol inhaler. If the patient is having to use the salbutamol inhaler more than 3 times a week, then that's what is known, or it indicates to us as clinicians that the asthma is poorly controlled. And in that case, we would want to speak to her, see what's going on, and see if there's something else that we can do to help her manage her asthma a little bit better. But once a week is absolutely fine and is of no concern. She's likely to develop a dry mouth with either inhaler. I have actually seen this a little bit being discussed on certain social medias. Not that I use them, but people send me them for some reason. I can't get away with it. People being worried that if you take an inhaler because it has a dry powder, that it's going to cause dryness of the mouth. This is not a common side effect, and is not something that we would expect from either of these inhalers. So it's not a counselling point we would be given when we're prescribing salbutamol or a corticosteroid to our patients. She may notice a slowing of her heart rate. Nope, this is a very, very uncommon side effect. There's no reason to assume that either of these medications is going to interfere with her cardiovascular system, so we wouldn't be reporting that. She should report muscle pains to her GP. Again, no. So this is something different. So this is for statins, as we discussed earlier. So statin treatment does quite often lead to muscle pains, myopathy, and also that rhabdomyolysis, which is a very serious side effect, which is why we want them to report back to us. But that's what we would expect from a statin therapy, not from either of these inhalers. She should rinse her mouth out after using the beclomethasone inhaler. And this one's correct. So I do know sometimes, because especially with other students and other clinicians, they get quite used to talking about salbutamol, that being the most common one, that they can sometimes forget this information. So because beclomethasone is an inhaled corticosteroid, it runs the risk, like steroids, they help to grow things. So if someone is taking the steroid, and in this case twice a day, it can actually increase the risk of a patient developing oral thrush, what's known as oral candidiasis. That's a very common side effect of inhaled corticosteroids. So to try and prevent that from happening, whenever you prescribe an oral corticosteroid, you want to advise them to rinse their mouth out so that there's less chance that this can occur. It just helps to wash away any of the residual powder from the mouth. She should take salbutamol prior to a precipitating event. And yep, that is absolutely correct. That's what we use salbutamol inhalers for. So salbutamol inhalers, they're a beta-2 agonist, and they're what's known as a SABA. So they're a short-acting beta agonist. And so we take these when or rather I should say a patient takes them when they can feel an asthma attack starting to come along. When the throat starts to constrict, the Beta-2 agonist works as a bronchodilator, and that helps to relieve acute asthma symptoms and to prevent any exercise-induced bronchoconstriction. As a result of that, if you have asthma and you know that you're about to go on some kind of exercise that might exacerbate it, or if you're going into a situation that might expose you to any known allergens, we would recommend that you take the salbutamol prior to doing that to help reduce the likelihood of an asthma exacerbation. So you can take the salbutamol inhaler when you have an asthma attack, or also if you're going to do something that would increase your risk of having an asthma attack, and that is absolutely fine to do. She should use her salbutamol inhaler each morning. No. Salbutamol inhalers should be used for symptom relief as necessary. And as I said, if you're going to be doing something that would reasonably assume that it's going to increase your risk of an asthma attack. And the biggest reason for this is that excessive use of salbutamol can lead to an individual building up a tolerance to it. So the body becomes more responsive to the medication's effect over time, which means when you do have an asthma attack or an acute exacerbation, it's less likely that taking that inhaler is going to be able to control it. And that's also why we want a patient to come and see us if they are taking it more than 3 times a week, because again, the asthma is not well controlled, and if they're trying to overcome the fact that the asthma is not well controlled by using a salbutamol inhaler, they run the risk of them becoming resistant to the treatment, and that's not what we want. And that's why we have literally dozens of different inhalers that we can try. So there's a lot of other stuff that we can go down the route of instead. And then finally, the beclomethasone is likely to cause weight gain, and this one can catch people out. So the reason that we like giving inhaled corticosteroids is because they have fewer systemic side effects compared to oral corticosteroids. So if a patient needs to take oral corticosteroids to handle their asthma, there is a risk. It's relatively small, but it is possible as a side effect that they will experience weight gain. However, with an inhaled corticosteroid, this is very uncommon, and so it's not something that we would be mentioning to our patient. Question 76. The current treatment fails to control her asthma. In order to develop a management plan for this patient, place 2 of the following options in order to provide a stepped care approach. So when we're managing a patient with asthma, depending on what region you're in, there'll usually be some kind of almost like flow chart or a stepwise management plan that you can follow. So when it comes to asthma, it's pretty consistent among most of the world from what I've seen. So we have this little diagram here, and pretty much from reading that, you should be able to get the answer. Obviously, in an exam, you don't necessarily have this to hand, but now would probably be a good time to stop the video, maybe make some notes, because this one does tend to come up quite often. So with this patient, would we add a chromome, such as sodium cromoglicate, add a long-acting beta-2 adrenoceptor agonist, such as salmeterol, an oral steroid, such as prednisolone, increase the dose of salbutamol, increase the dose of the inhaled steroid, such as beclomethasone, and I have copied this directly from the paper, and they have misspelled beclomethasone, fantastic. Oral histamines, oxygen therapy, replace the salbutamol with a long-acting beta-2 adrenoceptic agonist, such as salmeterol, salbutamol tablets, or use the salbutamol once each day. So let's go through these. So add a chromone, such as a sodium cromoglicate. So these are what's known as the mast cell stabilizers. So they help to prevent the release of inflammatory mediators from mast cells. They're not really used for control of asthma, or especially not as first line. They're reserved for patients with intermittent asthma or those that have exercise-induced asthma, but it's usually kind of a later step we would use in specific cases. It's not something that we would be recommending at this point, so it's not sodium cromoglicate. Add a long-acting beta-2 adrenoceptor agonist, such as salmeterol, and this would be one of the correct answers. So Salbutamol is what's known as a SABA, so that's a short-acting beta agonist. Long-acting ones do what says on the tin. They're bronchodilators that allow for long-term control of asthma symptoms, and they work in exactly the same ways as salbutamol. They act as bronchodilators to relax the smooth muscles of the airways. They tend to be the next step up from inhaled corticosteroids, especially in those where the asthma is not well controlled, or if a medium dose of inhaled corticosteroids doesn't work. So normally you try a low dose first, then we go up to a medium dose, and if the medium dose isn't helping the patient, then you would think about adding a LABA to the therapy. So this is one of them. I'm just going to leave it at that for now, and we'll decide which order we'll do it next. We'll add an oral steroid such as prednisolone. So oral steroids tend to be used for short courses to help manage acute exacerbations of asthma, but they tend not to be recommended for long-term control because, as we discussed in the previous question, they have the potential for systemic side effects. So some of these include, as we saw earlier, it can lead to weight gain, it can lead to diabetes, increased susceptibility of infections, because the way steroids work is that they lower your body's natural immune system. So why we favor inhaled corticosteroids is, yes, it's the exact same medication, but it doesn't have those same systemic effects because not as much is being absorbed into the body. So this one is only for serious complications, short-term control. We wouldn't want any patient to be on it long-term. It's going to just cause too many problems down the line, so not that one. Increase the dose of the inhaled steroid beclometazone. And if we follow this stepwise action, so we can see we're currently at step 3, where they're on a salbutamol inhaler and they have a medium dose of inhaled corticosteroids. Going up to step 4 is when we would be adding the LABA, or sometimes a montelukast, and if that fails, that's when we would increase the dose of the inhaled. So we go up at step 5 to a high dose of inhaled corticosteroids. So this is the other correct answer. And the order would be that we do this first. And oh my god, the settings all messed up. And then we do this second. So the first step is to add a LABA onto the treatment plan. And then if that fails, then we'll go on to increasing the dose of the inhaled corticosteroids. And then if either of those is still not controlling it, that's when we might consider giving the patient some oral corticosteroids. So we'll just quickly run through the rest of them. So oral histamines. So these are used to relieve symptoms of allergic rhinitis. They're not really used for asthma. This is more of an allergy medication. Oxygen therapy can be used to manage acute exacerbations of asthma, but again, not something that we want to be using long term. It's a short term option if something's gone really out of control. So it's not going to help them control it. Replace the salbutamol with a long-acting beta-2 adrenoceptor agonist. No, never do this. If someone has asthma, it's important that they have a SABA at all time. They have salbutamol all time. You don't want to be giving away a blue inhaler, because then if they have a sudden exacerbation, there's no medication that they can take. So you will add it alongside the salbutamol. You would never replace it. I mean, I think maybe there might be some very specific conditions where you might want to replace a SABA with a LABA, but at this stage when you're at medical school, and as far as I'm aware, we just wouldn't do that. Those are such unique and rare instances. Don't even be looking at that. Salbutamol tablets, again, these aren't typically used for long-term control of asthma. They're more acute symptom relief, and that's kind of something to remember when you're looking at dealing with asthma. Usually you want to go for something inhaled. If it's a tablet of any description, that almost always is for an acute exacerbation and shouldn't be recommended for long-term control. And then use the salbutamol once each day. Absolutely not. As we discussed earlier, that's going to lead to the body becoming resistant to salbutamol, and then suddenly that SABA is no longer doing its job. So never recommend for a patient to use it once a day. And as we mentioned previously, if they're using it more than 3 times a week, that is a cause for concern to have a bit of review because their asthma is not being controlled. Question 77. A 70-year-old man has right-sided heart failure secondary to moderate chronic obstructive pulmonary disease and is currently prescribed ramipril 5 mg daily, furosemide 50 mg once at night, and salbutamol inhaler which to be taken when it's necessary. The COPD is poorly managed and optimization of treatment might usefully include which one of the following? So acromone, such as sodium cromoglicate, an inhaled long-acting muscarinic receptor antagonist, intravenous hydrocortisone, oxygen therapy, or to replace the salbutamol with theophylline. So this is kind of along the same lines as the previous question. So COPD is a different disease to asthma, obviously, but the kind of treatment that we use is very similar. So we'll just quickly go through all of these. So acromone. So creams like sodium cromoglicate are not usually what we'd use as a first-line therapy for COPD. They're more used for patients with asthma and particularly with allergic conditions. They're not something that we would use for a degenerative condition such as COPD, so we wouldn't be using acromone. Next, we have an inhaled long-acting muscarinic receptor antagonist, and this is the correct answer. So this is what's referred to as a LAMA, and these are quite commonly used, especially in maintenance for patients with COPD, if their disease is not well managed, which in this patient of this 70-year-old it isn't. So LAMAs work by improving lung function and they reduce exacerbations, so they tend to improve the quality of life in a patient. So if it's not being looked after, we would go to that. And this is something which we will usually give straight away if it's seen that the patient has a moderate level of COPD. It can sometimes be given first line, so you have a LAMA along with a LABA, so that's a long-acting beta agonist. In this particular case, the patient was tried on something else and that hasn't been working, so the next step is to try a LAMA. So the other one, so intravenous hydrocortisone. So systemic corticosteroids can be used for exacerbations of COPD and they help to reduce inflammation, but they're not used as maintenance therapy. So there's nothing in this patient to indicate that there is a trigger that has caused an inflammatory response. It's something that is just being poorly managed. So inhaled corticosteroids are often used in combination with long-acting bronchodilators in patients which have frequent exacerbation of their COPD, but this patient is not quite at that level yet. That's probably something that we would try next, but for now it's best to try them just on a LAMA. Oxygen therapy is again recommended patients with severe COPD, but only when they have chronic hypoxemia. It's not specific in optimizing COPD treatment, so again, we wouldn't be doing this unless for their COPD got so bad that we'd be rushing them in. And even then, a key point is not relevant to this question, but it will come up quite often. If you have a patient with COPD and you put them on oxygen therapy, you want to make sure that you're aiming for oxygen saturations between 92 and 96%. The reason for that is because if you have oxygen higher, it can actually reduce their hypercapnic response, which can lead to type 2 respiratory failure. So you're giving them so much oxygen, but they're not able to actually blow the carbon dioxide off. So you have a buildup of carbon dioxide. So that's a very important thing that will come up whenever you're managing COPD. Okay, do not give them pure oxygen. Very bad idea. And then finally, replace the salbutamol with theophylline. Again, as we were talking about with asthma, never do this. It's very important for a patient to have the blue inhaler because this is for acute exacerbations of their symptoms. You always want to be adding on a therapy unless there's a very specific reason, like they're allergic to salbutamol, but you never want to take away a drug that is used to help them relieve symptoms in acute management. So just no, don't replace salbutamol unless it like specifically says that they're having like an allergic reaction or something to it. Question 78. A 25-year-old woman has been suffering from moderate depression and has been prescribed the serotonin selective reuptake inhibitor, or an SSRI, fluoxetine, 20 milligrams daily. In this case, which 3 of the following are appropriate counselling points? So a clinical response is likely within a 2 to 3 day period. Clinical response is likely within 2 to 4 weeks. A dry mouth is a common side effect. Be alert for bradycardia. Nausea is a common side effect. She should avoid cheese-containing products. She should doubt the dose during periods of stress. She should not take St. John's wort concurrently, or she should stop taking it once she feels better. Okay, so as I was mentioning before, whenever you have a medical question where there are 2 that seem to be not necessarily opposites, but seem to be talking about the same point, chances are that one of them is correct. So in this, we have a clinical response is likely within 2 to 3 days, or a clinical response is likely within 2 to 4 weeks. So medication for mental health, particularly selective serotonin reuptake inhibitors, they do take quite a long time, and it is very important that when you're prescribing this to patients that you let them know, because the last thing you want to have is a patient not being concordant with their medication. And it's quite a common thing to happen when someone is taking an SSRI or some kind of medication to help with depression or anxiety. They'll take it for maybe 4 or 5 days, say it's not working, it's not doing anything, and then they stop using it. Okay, so it's incredibly important to let them know that these kind of medications can take up to 4 weeks for them to actually have their therapeutic effect. And that can be quite a difficult conversation to have with your patient, but you need to, because a lot of time when they're coming into you, they'll already be at their breaking point, they're in distress, and they want the problem to stop now. And so it can be very tricky to navigate that situation, but you need to do your best to let them know, okay, we need to hold on for a little bit. It's going to take a few weeks, but you do need to persist with it, and it will hopefully, help you in the long run. A dry mouth is a common side effect. It's not a common side effect of fluoxetine. However, it is a common side effect of other medications that are similar in nature. So anticholinogenic medications, so tricyclic antidepressants such as amitriptyline, certain antihistamines, and some antipsychotic medications such as clozapine, yes, but not for fluoxetine specifically. Bradycardia, so that is slow heart rate, not a common effect of fluoxetine. You would expect it a little bit more with things like beta blockers or calcium channel blockers. So beta blockers are given for cardiac issues, but they're also sometimes given for patients with anxiety, and that helps to stop palpitations. So you'd expect bradycardia with something like that, so like propranolol, but again, not with selective serotonin reuptake inhibitor. Nausea is a common side effect, and unfortunately this is one of the, it's the correct answer and is one of the side effects when it comes to SSRIs. It usually diminishes after a few weeks, but again, this is one of those areas where there is non-concordance with patients. One, it takes a few weeks to get the therapeutic effect for their mental health, and 2, for the first few weeks it can make them feel a little bit sick. So it's one of those, again, why it's very important to be discussing with patients what they can expect so that they actually stay on the medication long term. She should avoid cheese-containing products. There's no interaction between fluoxetine and cheese-containing products. Off the top of my head, I don't actually know any medication that does. There probably is some, and when we get to it, we'll discuss it. But off the top of my head, I can't think of any, so that's a bit of an odd one. She should double the dose during periods of stress. Absolutely not. The dose should be consistent. If you're starting to increase the SSRI when you're stressed, it's going to just be messing with your body's regulation, circulation more. So you should stay on the medication consistently throughout. She should not take St. John's wort concurrently, and this is the third correct answer. So St. John's wort is a type of medication that's often taken by people. It doesn't require prescription. It's kind of a over over-the-counter medication because it's a herbal supplement. And the reason you don't want to be mixing these is twofold, actually. So St. John's wort can affect what's known as the P45 enzyme in the liver, and it also interacts in a similar way to other serotonin adjusting medication. So St. John's wort will have a synergistic antidepressive activity when it's partnered with another SSRI. And the problem with having too much serotonin is that it can lead to a condition known as serotonin syndrome. And this isn't just serious, this can kill people. So never take St. John's wort with another SSRI. And then finally, she should stop taking it once she feels better. No, again, this is another concordance issue. A lot of patients, once they feel good, will stop taking it. And because the medication takes a few weeks to build up, it then also takes a little while to build down. So patients will feel good, they'll stop taking it, thinking, oh, I don't need it, I'm cured. And then over time, it's quite insidious in nature, where the dark thoughts and the anxiety starts to come in. And before they know it, they're back where they were before, have to start the medication again, and it could again take several weeks for it to be built up. So you shouldn't be increasing your dosage when you're stressed, and you shouldn't stop taking it just because you feel better. So just to elaborate a little bit more with this serotonin syndrome. So this is something that occurs when the levels of serotonin are too high in a patient, and it causes a whole lot of problems. It can lead to confusion, dilated pupils, rapid heart rate, high blood pressure. You get extra sweating, so diaphosis, diarrhea, headache, shivering, a lot of nasty stuff. But some of the worst ones is that you can get tremor, you get certain muscle rigidity and stiffness because you're affecting a neurotransmitter. And in more serious cases, it can lead to seizures, unconsciousness, and it can kill people if it isn't treated correctly. So whenever you're dealing with an SSRI, a SNRI, so that's a serotonin norepinephrine reuptake inhibitor, certain tricyclic antidepressants, monoamine oxidase inhibitors, when you're taking any of that, and in fact, I guess a good rule of thumb is if you're taking any kind of mental health or antipsychotic medication, do not take St. John's wort at the same time, because it can have that synergistic effect and, well, death is a potential outcome. So question 79, and this will be the last one because the next question is kind of a run-on-one, goes on several, so 9 questions for today. So if this treatment fails after using the maximum dose and the patient is not considered at risk of suicide, the next step of therapy should be which one of the following? So is it a benzodiazepine, a monoamine oxidase inhibitor, a tricyclic antidepressant, carbamazepine, or lithium? So benzodiazepines are not typically used when it comes to depression, or specifically in a patient that only has depression. We tend to use benzodiazepines more for the management of symptoms of anxiety and sometimes insomnia. They're not what would be going when a patient just has depression. But if a patient is suffering from depression and anxiety, we might consider it as well. So it's not diazepam. Next, you have a monoamine oxidase inhibitor. So these are second-line treatment options for the treatment of depression. They tend to be not the first choice that we'd go to. We usually reserve these for when other antidepressants have failed. The reason for that is that they have some side effects, and they require dietary restrictions. So this again, I mean, it's technically classified as a second-line therapy, but realistically it's more second line if the other one hasn't worked, which to me makes it third line, but technically it's not considered third line. I know it's a little bit all over the place, but it's kind of like the alternative second line therapy. And the reason for that is if an SSRI hasn't worked first, what we would be doing is trying them on a tricyclic antidepressant. So according to the NICE guidelines, these are what we would go for the second line treatment when an SSRI like fluoxetine fails to produce that adequate response, and especially if the patient is at risk of suicide. In this particular case, the patient is not at risk of suicide, which is fantastic, but even if they were, we would be starting them on a tricyclic antidepressant as second line. So then you have carbamazepine. So carbamazepine is an anticonvulsive medication, and we don't usually use it for treatment. It's more like an adjunctive treatment if a patient is suffering from what's known as refractory depression, but it's not what we would use as the next line when an SSRI has failed in this kind of context. And then finally we have lithium. So lithium is used as a mood stabilizer, and it's most often used in patients that suffer from bipolar disorder. There is some evidence to suggest that it could have efficacy in treatments of depression. I mean, it's a little bit of a weird one because bipolar disorder did used to be referred to as manic depression. So there is a little bit of overlap between the two, and that's why historically it's been quite difficult to treat them. But lithium more for bipolar disorder than depression. So then just a little bit more on that refractory depression we're talking about. So it's also known as treatment-resistant depression, and that tends to occur when the depression hasn't responded adequately to 2 or more different types of medication. At that point, we might be considering the monoamine oxidase inhibitor or carbamazepine, but usually that is more of a third-line option. In addition, there's some other stuff we can do, such as psychotherapy, some vagus nerve stimulation, but that's a little bit beyond what we're covering for today. So I'll leave it there. Look forward to seeing you next time, and have a wonderful rest of the day.